Hello everyone, my name is Sarah. I'm going to be demonstrating a newborn assessment. Here I have a troll that I'm going to demonstrate on because I do not have a newborn baby to assess. So typically when baby's born, we want to dry them off with clean towels. And once those are wet, we want to exchange them for new ones. Typically, mom and dad want to know weight, size, and all that of baby. So what we're going to do first is get the baby's weight in pounds or ounces. Kilograms for us is what we like to document. So we're just going to say baby Jasmine is 6 pounds 3 ounces. And then we're also going to get the length. You can do a few different ways, but we can do top of the head. Let me put this a little bit lower. So we can do top of head to the end of the feet. And we'll just say little Jasmine is 20.5 inches. Safety is also important. So when you're doing this, make sure that you are in a safe area. You have your little side rails up on this and the little bassinet at the hospital. Or if you're doing it on the baby warmer in the nursery. So now that I've done the measurements, I'm going to go ahead and take the circumference of 3 spots on baby Jasmine. We're going to do her head, we're going to do her chest, and then we're going to do her abdomen. So I'm going to go ahead and get my tape measure. And we're going to do head circumference. So head circumference is 17 inches. We're going to do chest circumference. And make sure that when you're doing these measurements that you're consistently measuring the same area, because when you document, the person that's looking at the assessment knows exactly where you've been measuring. 14 and a half. And then we're going to do the largest part, the abdomen. Typically babies have little big stomachs, so 16 inches there. Now we're going to move on to vital signs, which is very, very important. We're going to go ahead and do the blood pressure, pulse, respiratory rate, and temperature. So with blood pressure, babies are typically a lot lower than adults. And then their pulses, babies are always born, or most of the time, have a regular heart rate. So we're going to listen for a full minute. So I'm going to go ahead and do that right now. And I would clean my stethoscopes, of course. So I'll listen for a full minute. And we want something that's between 110 to 160. Okay, and then we can also listen to them in all 4 spots, which is the aortic, pulmonary, Erb's point, tricuspid, and the mitral valve. So everything checks out, it's fine, normal. While I am listening to heart rate, I'm going to go ahead and listen to the respiratory rate as well. It's kind of hard to hear it because babies' heart rates are very, very fast. But that's why you want to see and visually look at their respirations along with listening. Okay, and then we take a axillary temperature. With baby, we don't do rectal temperature because we just don't want to cause any damage in the rectal area. So I would take her temperature right here. And we want to look for, and we want to have a 98-degree baby. Anything lower, you're going to want to swaddle them with 2 blankets instead of 1, which is very important. Okay, baby Jasmine is 98, which is totally fine. We also do assess pain in babies. Typically, babies have different cries for different meanings. They can't verbally say that they're in pain, but we can note pain levels with different types of cries. Especially when babies are getting circumcised, you'll notice that cry is significantly different than if a baby is hungry or if a baby's just wanting to be held. So just note that. So I auscultated the lungs. Now I'm going to auscultate the lungs. Since I already since I already cleaned my stethoscopes, I don't have to do it again. And I already did my heart. So now I'm going to do the lungs. You would normally want a newborn or a peds stethoscope because it's a lot smaller. And then you're going to get baby, put them on back like this, and you'll listen to the heart or the lungs on this. Okay, everything's fine. Baby might have wettish lungs just due to the amniotic fluid that's been in since they've been in the mom's womb, which is totally fine. It'll kind of clear up as the older they get. So now I'm gonna do the full, got the most important things, of course, the vitals, seeing what everything is normal. Now I'm gonna go ahead and take a look at baby's skin color, texture, and such like that. So when I see baby, I notice that baby's pink, Jasmine's pink. It's also very common for babies to have acrocyanosis just because the fingers and the toes are the last place that the oxygenated blood perfuses to. So that's totally normal, and it would be like a 9 on an Apgar scale. So we would look for baby color, texture. Texture is typically smooth, baby smooth. If they're more premature, they might have like a kind of like a sticky sensation, or not a sensation, but a texture. Turgor tube skin's very smooth. We're also going to check for any excess hair, which typically falls off or always falls off. It's just baby hair. That's called lanugo. And then we're going to look for any rashes, stork bites, any scratches on the face, things like that, which is all very kind of common. And then we're going to also look for Mongolian spots. These kind of look like bruises on the back. So they're going to be typically kind of on the buttocks area, kind of on the upper back. And we would just document that as Mongolian spots, which is totally normal, fine. Very, very common in babies. And then we're also going to look for the vernix, which is kind of that cheesy looking white stuff babies have when they first are being delivered, C-section or vaginal birth. We want to note that that's very normal and it's kind of a protective barrier. So leaving that on just a little bit like around the necks and the armpits, totally normal to keep that on, so you don't have to completely like wipe it off or anything like that. And then I said stork bites and just like scratches and such like that. So baby Jasmine looks fine. She might have a stork bite right here, a Mongolian spot. Other than that, she looks perfectly healthy at this point. Now going on to the really, really important aspect of a newborn assessment is the reflexes. So anything noted now is very important for proper interventions later on. So we want to make sure all reflexes are normal, and if they're abnormal, you want to document that and make sure that the healthcare provider is going to, or their pediatrician is aware of these documentations. So the first one we're going to do is the Moro reflex, which is very commonly seen when baby's just sometimes laying there, and it's like a startle reflex. But if you want to, maybe if they're asleep, but if you want to maybe kind of like startle them, try to startle them and try to get them to like react, it's really good. It's really, you can really see it when they're not like swaddled in the blanket. So maybe when they're first on that bassinet or the baby warmer, you'll be able to really tell. You're going to also check for blinking. So their eyes are going to typically always be very swollen, and they're going to be shut because they're sleepy, of course, but you're going to look at the pupil reflex and just maybe do the eye. You're going to, right, look at just look at pupillary reflex. Make sure they're both contracting or constricting as they're supposed to. And then there's also another important one called the rooting reflex. So what you're going to do with this, you're just going to run your finger, mind you, the gloves, you're going to have gloves on and you're going to have already scrubbed in, but you're going to run your finger along their cheek. What they're typically going to do is face you and turn their face. So that's a good sign, and that they have that rooting reflex. While you're doing that, you're going to place your finger in their mouth and they're going to go ahead and do that sucking reflex. It's natural for them. They're going to start sucking on your finger. And while you're in there, you can go ahead and assess and check for the hard and soft palate to make sure there's no kind of cleft palate. But typically with cleft palate, you can physically see like an abnormality around the lip area. But go ahead and check for the sucking and then the palate and such. And then same with the fingers, you're gonna a reflex with the fingers. So you're gonna have baby grasp your fingers, and if they kind of clench on like this, that's normal. That's what they're supposed to. That's what's supposed to happen. Same thing with feet. They're gonna kind of curl their feet onto your finger. We also have another reflex test. It's called the Babinski reflex. So this is just gonna be a is it an upside down J? And it kind of like fans their toes. Their fingers will be like fanned. So that's good to see that. We're gonna also have the tonic neck flexor or the fencer, which is you're gonna have baby, or you're gonna set baby on their back, and then you're gonna physically turn their head this way, and then their natural reflex is gonna have their arm is gonna follow along with their leg, or this arm. So wherever they turn to, they're naturally gonna have their arm turn towards it along with this leg. Same thing, you check both sides. So that arm's gonna follow and that leg as well. And then we have the trunk incurvation. So you're gonna have either baby on the back or the stomach. Go ahead and place baby on stomach, Jasmine. Head's facing this way, and you're gonna run your finger along the side of their belly, and they're gonna kind of turn towards you. So if you're going like that, they're gonna kind of turn towards you, which is fine, it's normal. And then while baby's on stomach, you're gonna look for that prone crawl, which is kind of just them scooching up. So we want to see all that. So baby Jasmine has all her reflexes, and she is healthy up until this point. So we're looking good. Now I'm going to check her head out. So baby Jasmine was delivered via vaginal birth. So I'm just looking at the shape of her head, and I'm going to look if there's any molding. You kind of have to like fill in there. Baby's heads are very soft, so can't do it too hard. But you're going to fill molding, maybe a little caput, and you're going to fill the two fontanelles that are fusing. It's going to be one up top and then that one at the back of their head. You know, anterior, posterior fontanelle. The fontanelle should be flat. And then if baby Jasmine maybe had needed a vacuum suction vaginal delivery, you might see a hematoma, cephalohematoma. So you're going to look at any bruising here. Same thing if she needed a forceps, if she was C-section, you would maybe see like marks on her face, like around her cheeks, maybe bruises or lacerations. So yeah, that's good with her head, progressing good, she's healthy. So we're gonna move down to her face. So baby Jasmine's cute. We're looking for symmetry though with face, so making sure that her eyes are symmetrical, her ears are symmetrical, her mouth and her nose. And we're gonna make sure that again, checking her face, if she had any forceps delivery problems, then you'll see typically you'll see like kind of bruisings around this area, or even cuts as well. And then of course if she was delivered and the doctor used a vacuum, it's a big suction on the top of their head, so they're going to have a very kind of like pointed head, and it's going to be very bruised, and it's it looks painful. And then we're also going to look for milia, which is kind of just like blemish marks, but you don't pop them or anything. They're just totally normal. And then you're also going to look for breathing. Babies are nose breathers, so you're just going to see, you'll see breathing their nostrils. If they're labored, you're going to see that they're flaring a lot. So you want to note that. That's abnormal. We also kind of want to look at tongue, make sure it's freely movable because we have a thing in our mouth that is connected, our tongue to our soft palate. And if that is connected, then we need to note that and you know, tell healthcare providers because sometimes they go in there and maybe cut it so that the tongue is freely movable because it makes for latching on very difficult if they have that. So we also want to make sure the eyes line up to the ears, and if they don't, then this could indicate some type of chromosomal abnormalities. So we want to note that if we see that. It's not diagnostic, but it kind of hints to that there might be some. And then we also want to look for recoil in the ears. It's just cartilage. We make sure. Newborn babies typically have it. If they're premature, or if they're full term, if they're premature, they might not have developed that cartilage, so you're not gonna see that. We're also gonna check the ear canals to make sure there's an actual ear canal in there. We're gonna note if there is, then you would obviously document that. And with baby and with hearing, typically when they're brought out from the nursery and going into mom's room, they're going to recognize mom's voice and they'll turn their head or they'll search for mom's breast if they're breastfeeding or things like that. So you'll kind of know if baby is able to hear. So recognizing voices, and then along with the eyes, pupillary reflexes, and we're going to check eyelids, eye color. Typically babies have dark eyes and they kind of change into the color that they're going to be later on within a couple weeks or so. So we're looking at that. The conjunctiva, we're going to look at, we're just going to pull that kind of eyelid down, look at that, look at the sclera, conjunctiva, and all that. So you want to do this obviously before the erythromycin ointment is put in their eyes, because once that's in there, you can't tell. It's very it's like Vaseline substance, so their eyes aren't able to like open very well after that. It's just an antibiotic for prophylactics antibiotic. Now, done with the face. Baby Jasmine looks fine. Now we're going to go down to the neck. We're going to see if there's any extra folds, if baby's neck is freely movable. And then we're going to look at the symmetry with this as well. We're going to look at clavicle, see if there's any damage. Sometimes if there is damage to the clavicle, there's going to be asymmetrical movement. Maybe one side is going to be stuck still while the other one is movable. So you want to look at that. And then now that we looked at this, baby Jasmine's fine. We're going to go down to chest. So we already took her circumference. We're just looking at the appearance and making sure that she's breathing normally. She's not over exaggerating with her breathing or using like accessory muscles while she's breathing, making sure she's expanding and retracting with her breath, but not labored breathing. We don't want labored breathing because baby Jasmine is new to the world, and we don't want to overexhaust her, or she doesn't need to be overexhausted because she is going to have issues with keeping her body temperature because she's burning off calories. Her glucose is going to be bad and low, so we want to make sure that there's no labored breathing. We already auscultated lungs. She sound fine, maybe a little bit of wetness from the amniotic fluid or that water. You'll notice, from my experience, I have heard a grunting baby, and it sounds pretty bad. So you'll definitely know if baby's struggling to breathe. Their diaphragm and their chest and their abdomen, it's really clear that they are struggling to breathe, and they're typically put on ordered oxygen for that. And yeah. So, but baby Jasmine looks fine, no grunting. Lungs sound fine. She's expanding and retraction fine. Appearance is normal. Buds are normal. And that looks about right on this. Chest is fine. Now I'm going to go to the abdomen. We already took the circumference of abdomen, which was 16 inches. We're just looking at the appearance of abdomen, maybe noting any scratches or anything like that. We're also paying close attention to this umbilical cord and make sure it's clamped. When baby's first born, it's still going to have that Wharton's jelly on it, so it's going to be maybe wet looking, but it will dry up. And the umbilical cord will be dried up and the clamp will be on. So we're just looking at that to make sure there's no, just no discharge, swelling, or any signs of infection at this area. And then we're going to look at the femoral pulses, which is down here. We're going to kind of look right here, take those pulses, and then we're going to kind of make sure that there's no hernias or any abnormalities or anything like that. So baby Jasmine's fine, no hernias. Now we're going to go down to the truncator part of the body, the end of her, like her legs. We're looking at extremities as well. We're making sure baby Jasmine has all 10 fingers and all 10 toes, very important, and note any webbing or any extra growths or anything like that, any extra skin or anything like that. So we have that arms, and also when we're checking this baby, when baby's first born, she's typically going to be moving a lot, and you'll be able to tell if she's symmetrical, asymmetrical. So you're just making sure she's, moving and such. So she looks fine. We also have the doctor, and we do it as well. We do a technique or procedure, not a procedure, but just checking for extremities and any hip dislocations or anything like that. But it's called the Ortolani. So this is just checking for hip dislocation. So what you're going to do to make sure that you're holding on to the baby right here, and then you're just checking for any type of dislocation. Typically, if there is a dislocation, you'll kind of feel that there's a catch. It's like catching. And that's a sign that baby girl's hip is dislocated. So now that we checked her extremities, she has everything, all toes and fingers. We checked her hip, no dislocation. We're gonna also check her legs to see if there's any abnormalities. She is symmetrical with her movements. Now we're gonna turn her on her stomach, and we're gonna look at her spine. So babies are born with like a C-shaped spine. And this is just, when you're checking spine, you also want to look for any hairy patches or any kind of indentations anywhere, because that could indicate like spina bifida, if there's like a indentation in this area, or if any patchy areas, that could indicate chromosomal abnormalities again. So now that we checked trunk, fingers, everything's in place, we're going to go down to the genitalia. So this is baby girl Jasmine. So with this, we're going to look for, we're going to look at labia, the clitoris, the mons, maybe minor and major. And typically, sometimes we see like bloody discharge, and that's just normal. It's from mom's hormones and stuff. Totally normal, but we're just looking symmetric again, if there's any other abnormalities or anything like that. The labias are pretty pronounced and kind of swollen looking, and it will kind of subside once baby gets older, once baby girl gets older. And then we can also look at anus and see if there's any type of abnormalities or anything like that. Now, if we had a baby boy, we would look to see if the urethra is at the top of the penis and not underneath it, because we want to make sure that baby boy is able to pee correctly and boy normally. And then you would also look at the scrotum, and then you would look at that rugae, all those like kind of wrinkles on the scrotum area, and just kind of note that appearance. And then you'll palpate the actual scrotum as well to see if the testicles have descended, and you would obviously chart that. So normal finding. Also, if baby boy is having a circumcision, this is very important. We want to make sure that he has voided before he has left, because we want to know that the doctor hasn't damaged any type of nerves or anything like that. So we want to make sure baby boy has voided before he has left the hospital if he has had a circumcision. And with the circumcision, we're just looking at discharge and making sure that he's healing properly and such. It does look worse before it does look better, so we'll keep that in mind. With elimination, so babies typically will have 1 a day, preceding the next day they'll have 2 and 3 and 4 and 5 and so on. And then their bowel movements, they usually have, or they'll always have, if they're full-term babies and healthy, they'll have 2 to 3 meconium bowel movements, which is kind of like that black tarry substance that comes out, and it's very hard to wipe off. So when you're changing baby, make sure that you're wiping properly. Getting a warm water helps with baby wipes. Also, if baby is breastfeeding, their poop will be more liquidy, and it'll be a lighter yellow. Whereas a formula fed baby, their stools are going to be a lot more formed and darker and have a more potent odor. So that's one thing to keep in mind. Also, we want to look at the overall appearance of baby the first 24 hours if they have developed any type of pathological jaundice. So this is very bad. If they've have jaundice within the first 24 hours, this is bad, and this needs to be closely monitored. So what jaundice is a overaccumulation of bilirubin in the baby's blood, and this happens due to the liver being in overdrive. Baby girl, baby boy has just been born. It's kind of overwhelmed. It hasn't ever been outside the womb. So it's just this buildup of bilirubin, and it's because it's not the baby's not being able to break down those red blood cells properly. So their skin kind of becomes a pigmented yellow. You'll kind of notice it around the sclera, like their eyes. So there's that kind, the pathological, which is bad. And then there's also the physiological, which is not as bad. It kind of happens within the 2 or 3 days after baby's born. And this is just, they need a little extra help. They're typically put under like a light for a couple hours. Depending on levels, some babies that have jaundice, they can stay under one of the lights for a long time. It just depends on how they're able to break down those red blood cells and excrete that bilirubin. We want to make sure that baby's voiding correctly and noting wet diapers and poopy diapers, and overall appearance, because babies can change their things can go wrong with them, and when they do, we need to because they're so tiny, so we need to make sure that we're on top of documenting and all that. And so I went over everything: weight, length, vitals, skin color. Went over the reflexes. I went over the head, the face, mouth, eyes, nose, ears, the neck, chest, abdomen, extremities in the trunk, the genitalia, elimination pattern, and big things to notice with jaundice. And that concludes my newborn assessment. Thank you.